Okay, there. um, this is part 3, basics of 12 leads. Well, a combination of basics, intermediate principles, and advanced. This might be the last video in this series because I think I've kind of talked about most of the basics. The goal of this was to not teach people about ECGs per se. Like, it wasn't meant to really be an introductory to cardiology lecture. It was meant to kind of provide a systematic approach. And then I use sort of the way that I analyze 12 leads as the guide here. Because of the way that I analyze 12 leads utilizes a lot of basic principles kind of stacked on top of each other, I figured I'd extrapolate on what those basic principles were and then provide some context as to why they make sense. I focused on conceptual knowledge instead of memorizing rote memorization facts. The reason I did that is because I kind of feel like if you just memorize, then you could either apply that memorization incorrectly or not apply it when you need to, because all you've done is memorize rules instead of principles, theories, philosophies, concepts, all that stuff. So now that I've done the first 2 videos, I have a better idea of where we started and where we are now. So I will go over, I won't review it like I did in the last year because it took me a half hour both times, but I'm going to say what's important to memorize. Memorize a normal EKG. Memorize a 12 lead. Get intimately familiar with what a normal one looks like so that even if you don't know how to define it, you can say that your 12 lead currently is abnormal. In the presence of potential cardiac symptoms or definitive acute coronary syndromes, an abnormal ECG, especially one that changes from one ECG to the next, is oftentimes problematic and should be considered clinically significant until ruled out by, troponins, and maybe even ruled out by cath in certain instances if it's not a, full-blown STEMI or whatever. So the next thing then, which I haven't talked about in the first 2 videos, is where in the heart the areas are. Here you go. So look this up. If I have, these are areas that are next to each other. Of course, yeah, V1 and V2, LAD. But if V2, V3 has elevation, would you say, well, it's not 2 or more contiguous leads because these are contiguous? Yeah, they are. They're right next to each other. Anything in the precordial section, here to here, here to here, here to here, is consecutive, in my opinion. Here and here, I can't really speculate as to what that would mean as like a 100% rule. But this I forgot to say. So memorize this, or, maybe not memorize. Oh, I don't endorse anybody in particular except for Wave Maven. But yeah, get familiar with this. Parts of the heart. It's a bad picture. Here we go. Yep. Additionally, another good thing to commit to memory, get very familiar with rather, would be the coronary arteries, where they run. That way, if you've identified a problematic area here in the inferior section, you could say, that's the inferior section. What artery feeds it? Oh, the right coronary artery. Ah, this is a congruent section, contiguous section. Lateral, that's down here somewhere. Could it be the left circumflex? Yeah. I mean, that kind of spits around back. It's probably more likely to be one of the distal parts of the LAD, one of the diagonal or middle branches. Yeah, stuff like that. Are there other things that can interrupt blood flow and cause ST changes, like just ischemia in general, coronary artery dissection, aneurysm, aortic root problem? Because when I went through the cardiac anatomy on this last lecture, I didn't actually talk about the coronary sulcus or the principle of these feeding during diastole or anything like that. So let's make a new list, shall we? Anatomy, physiology, of the heart. If you're more advanced, throw the lungs in there too, because anything that's next to one thing that's affected could affect the other. Systole, diastole, right? Your measurements like cardiac output equals stroke volume times heart rate, things like that. Things like SVR, vascular resistance. If you're into critical care, you'd want to know about pressures, arterial, venous, chamber pressures. You'd want to know how blood flows through the heart, how gravity fills chambers, and then causing valves to close. So there's no, so that way there's no avoids regurgitation of leaflets, right? Things like that. A normal 12 lead injury location, right? Inferior, you know, what part of the heart the leads represent. Then we get into normal heart rates for age ranges. Assuming sinus rhythm, 60 to 100. Faster for pediatrics. I don't know. Infants, even faster. Neonates, like probably that fast. And then memorize something like this. Yep. And then also this height for every lead. And then apply your basics, come up with some sort of systematic approach or rule, and apply your basics and go A, B, C, D, E, F, G. A, B, C, D, E, F, G for everyone until it gets easy for you. What you will end up on doing is identifying A, B, and C at the same time. Or you'll look at it and you'll just start identifying things that pop out easier. So you can get to a diagnosis quicker the more you practice, but you have to do A, B, C, D, E, F, G. And then every single time, even if you do really, really hard ones, I still do components of A, B, C, D, E, F, G, and I just stack them on top of each other. It's just layered basics. Every concept by itself, if explained in isolation, is basic, but added on top of each other in the correct sequence with the correct conceptual knowledge is advanced. So just don't shortcut yourself and just do all of the basics every single time until you get better at them. And when you get better at them, start incorporating new stuff. And don't move on until you have a conceptual understanding. Like you have to understand the concept. You have to visualize it. You have to be able to teach it. If you can tell somebody what it is and actually, and then answer their questions, you have to have such a, full understanding of that. That's conceptual knowledge. You might not remember that the interval is 0.2 because it's a Tuesday and the moon is blah, blah, blah. Like you might not know the exact specifics. And then the last thing of sort of like anatomical memorization would be this. And I tried to be as dramatic as I could when I said the word exact. I did not mean 99%. I meant 100% exact. There's some other tidbits that I can offer. Like I don't ever do V4R. Why would anybody do that? Just flip the whole thing and do an entire right-sided ECG. If you're worried about the right side of the heart, if you were worried about the structural integrity of the roof, why would you go and just check one section of the roof? You would check the frame, the roof, the eaves, the gutters, the support beams, the inside of the roof. You check the whole thing. You wouldn't just look at the chimney. So why would you just do V4R? Another kind of tidbit caveat with this is my personal opinion is I don't really see the benefit of doing a posterior ECG. I think they're done infrequently. So I think the likelihood of making a lead placement error. Oh man, they did an entire posterior one. Interesting. Yeah, so you're more likely to make an error here. You're more likely to put it over bone. And then the patient is probably more likely to lay down on them, which could increase interference and artifact. Furthermore, there's more muscle back here than there is on the rib cage. You're not putting these on the actual chest pectoris muscle, they're below. So it's below the pec muscle. So these are likely to be more dampened. So I wouldn't waste time with it, but I also wouldn't waste time with V4R because you might miss something. Who knows that? You can tell me with certainty what the exact position of that patient's heart is inside their chest cavity. You can do that without an ultrasound or an X-ray. Huh, interesting. Good for you. So you might miss something if you put here versus here. So do the entire thing. Why wouldn't you do the entire thing? Anyways, a couple tidbits. So to summarize, we're talking about memorizing rates. Oh, and when these rates memorize per area, so the sinoatrial node, AV node, bundle, or sorry, septal area, right? And then as you go down to the Purkinje fibers, it's really slow. And you may actually get like an idioventricular rhythm or like almost a cardiac standstill. That's like, 2 beats a minute. I just look like a really big PVC. And then we also talked about the cardiac conduction system. Talked about the left and the right side of the heart. It's kind of acting separately, but the vectors drawn together. Oh, and we talked about axis. So, and R wave progression. So, let's get rid of that. Let's get rid of that. So we'll say rates and conduction system. Yep. Yeah, that's good. That's it. That's like the heart in a nutshell. Congenital conditions, yeah. Pediatrics, neonates, different than adults. Yep. Pulmonary conditions leading to cardiac problems called cor pulmonale. Yeah. Genetic things. Oh yeah. Electrolytes, a bunch of crazy stuff. Yep. But you can't layer anything about that on until you know this. Because cardiac output doesn't like really matter in the term and for recognizing ECGs. And then also just know that anytime there's something that interferes with electrical capture from the ECG leads on the chest, anything that dampens that electrical signal, it moves well through just a little bit of tissue and just a little bit of air. Okay, hyperinflated lungs, subcutaneous fat / obesity / positioning, depending on patient's condition. Like if they can't lie flat, or if they can't sit up, or they have to lay like, I don't know, how you doing a 12 lead on a prone patient, maybe like that picture that they just showed. Also, other things that cause problems inside the chest, abnormal fluid collections. This could be anywhere, in the lungs, in the thorax, mediastinum, pneumothorax, mediastinitis, whatever. Cancers, pleural effusions. Yep. Or cardiac tamponade in the setting of well, I mean, yeah, it doesn't have to be life-threatening. You could have a lot of fluid inside of a pleural effusion. Anywho, yep, that's the basics. So those are things that you have to commit to memory. And then in terms of like imagining stuff, intervals, what the waves look like, what a normal 12 lead looks like. If you think of that every single time, you have to make a conscious effort to think about it when you do 12 leads. But after that, you'll notice like day after day, hour after hour, EKG after EKG, year after year, you'll start consciously thinking about less and less. And you'll start just subconsciously being able to recognize it. And then to be truthful, I can recognize these ECGs a lot easier and quicker than what I'm doing now. If I was looking at the answers, the 4 answers, I could probably make an appropriate selection 90% of the time within 5 seconds, maybe 10 seconds. It takes me a long time to analyze them because I've gotten so used to analyzing all the basic stuff that I actually, I have to consciously think about the things that I normally glance over because I just like, yep, normal, 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 normal. Now it's gotten so familiar where the stuff, only the abnormal stuff pops out to me. So to go back and explain the normal stuff actually takes longer. So that's how kind of how it works, right? And you'll find that happens with you you all as you go through this call. So let's go to WaveMaven, and let's kind of add it all up together. And I promise you, I'm doing this with moral integrity in mind. I don't remember where we got to last time. Definitely past here. Oh yeah, that was our last one. Okay, so let's cover this up and let's go to some zoomable stuff. I'll keep this up. I'll keep this up. And since we're only like 20 minutes in, 16 minutes in, I have a feeling we'll be able to get like 3 or 4 of these. Okay, let's do basics. Normal, nope. Slow or fast? Fast. So abnormal and fast. Any hemodynamic symptoms with this patient, I would immediately begin to investigate why. I would immediately try to determine is this primary or secondary cardiac. Primary cardiac? At this rate? Yeah, I don't know. But I mean, it's faster than 150. And it's irregular. Looks like AFib. Anywho, let's go through some stuff, right? So I honestly don't think that this is regular. Here's why. Here to here is almost exactly 150 beats. But if it was regular, then why is it changing? This should be on this line, right? I don't really see deliberate P waves. There is some notching. Actually, that looks like a delta wave. There's an R prime. Huh. There are some slurring effects that happen sometimes with like AV NRTs. You're trying to think like, is it an AV nodal reentrant or non-reentrant or non-AV node atrial tachycardia? I don't really see P waves. Sometimes it's tough. Sometimes there's things where like a 2-to-1 A flutter can look almost like an SVT with a relatively non-variable rate. That looks weird. I wonder if that's an artifact. Well, there it is again and again. But it's not there. Is there some sort of AV node dissociation going? Well, I don't know. Anyways, let's see the axes. Thumb up, thumb midway. So although I wouldn't call this right axis deviation, I would definitely say it's leaning a little bit towards the right. Tachycardias can start, the faster the heart rate is, can start to produce an aberrancy-like thing. So it's not surprising that with a faster heart rate, the axis is shifting a little bit. Because normally these tachycardias don't exist here. Sinus tach at a perfect rate in an elderly person, although I didn't read what the patient's age was, but assuming they're old, sinus tach doesn't really go above like 150 to 160. When it does, it's usually in a younger patient. Cheapers. Anyways, what I was getting at here was that if you have something like originating here, originating here, originating here, because it's not super wide, so wherever it's originating, it's kind of high up. This bends the axis. If instead of being here, it's a little bit rightward here, well, that's pushed to the right, isn't it? It's originating here. That's literally to the right. That could cause slight right axis deviation. It's not like this, but it's more rightward. So something like that. You know, all the ventricles have an outflow tract between like here and here. Certain outflow tract tachycardias can do that, although that I don't. This seems a little bit too narrow and a little bit too fast for that. But you know, after my lessons learned from the other ones, never discount anything, right? Anything, right? Having a P wave looking thing. I mean, this literally looks like it's 4 beats in a row. What are the odds that the artifact occurs in the same spot 4 beats in a row? That almost looks like it went, well, and the amplitude of the R wave here is 50-50, and then it's a lot smaller here. What shortens the R wave? What shortens the R wave is coming up this way. Because remember your lead if you're in like V1 and everything goes towards it. So perhaps we have some degree of a paroxysmal SVT, or this could even be a 2-to-1 A flutter, and the flutter wave is buried by the preceding T wave, alternating with an AVNRT. So the P wave is after, which to me would indicate that there's this like circular thing going on. Right at the AV node, you see it originates here and it causes ventricular depolarization, but at the same time, the atrial activity does this. So briefly, the atrial activity goes towards that lead, and when it goes towards the lead, it's a positive deflection, but it's occurring after the septum activates, which means it's going to occur after the QRS complex starts. So this part here looks like an AVNRT. See? Yeah, this right here looks scooped and wide compared to this. So something's happening here and the rate is different. Maybe not the rate, but the rhythm's certainly different. This has gotten taller consistently. I mean, honestly, the gain is a little bit small, so it's kind of hard to really appreciate it, but this is noticeably bigger than this, taller. And this is deep. And since the RS wave changed in its morphology from here to here, and then there's this notching at the end of it, which to me probably indicates an AVNRT, like post-septal activation atrial activity. I don't know. It looks like it's a little scooped here too. I think this is something paroxysmal. There's this little dip right here. That's interesting. Little notch, little notch. I can't tell if that's artifact or a PVC. Either way. Let's march it all out in lead 2. It does appear slightly irregular. And then we have this thing happen right here where like the size of this changes. It gets bigger and the amplitude of the R wave gets taller. It does kind of look like it's getting, like it's alternating, doesn't it? Because the isoelectric line is the exact same. This is low, high, low, high. Maybe it's changing with breathing. Huh. I'd be curious to know if this patient had a breathing problem or if they had a cardiac problem. Maybe they have like a tamponade or something. Some sort of fusion. The R wave transition is delayed, but it does transition. The T waves honestly look okay. They're a little flat in lead 3. Isolated T wave abnormalities in lead 3 without clinical context, in my opinion, doesn't really mean much. There's a large R prime here. When things start going on with AVR, I suspect that the rhythm's not originating in the sinoatrial node. Like the second half of this, it's going towards it. So that, you know, somewhere down near the junction, the AV node. Well, let's find out some context because I don't really. This one's interesting. There's a slight wandering baseline when we get here, but honestly, it looks like there's a variable R wave peak, and it's associated with a change in size of this S wave, large and small, large And it looks like it's large for the rest of it. Then there's some artifacts, so I can't tell. It's kind of bizarre. What I'm going to say, my gut tells me it's not atrial. Well, sorry, it's not sinus. It's either a very regular, an abnormally regular AFib, but I don't know about that. I mean, the faster an AFib goes, the more regular it does appear. You know, you can't have an AFib of like 190 to 220 and really expect to see much variance between the R to R. So it could definitely be AFib, but the morphology's changed. So there's definitely something like different going on in one part of the EKG compared to the next. Additionally, it does look like there's notching here, and then that looks like an accessory pathway, doesn't it? That looks like a delta wave, but it's notched here. So this seems like it's an intermittent. I mean, I don't know, the classic they talk about in school is Wolff Parkinson White. It just seems like there's something going, like it's one way or another. It's very subtle. It's atrial-ish, not sinus. And the access and the RF transition are relatively normal, slightly abnormal, but without any clinical context, previous EKGs, patient age, or cardiac history status, it's very tough to know for sure. Like this might just be the patient's baseline. And the structural heart abnormalities may be like years of heart failure and cardiac disease. So let's see. I bet it's going to be like an old patient with shortness of breath. Or some sort of vague symptom. I suppose they could have chest pain. Let's see. 49-year-old. Oh, younger than I thought. Woman with a rapid heartbeat has the following ECG. A flutter with a 2-to-1 AV block. I buy that. AV nodal reentrant tachycardia. And part of it looks like that's what it is. AFib looks slightly too regular for that. Atrial tachycardia. I don't see enough P wave activity to definitively say that. Sinus tachycardia, absolutely not. Okay, so now we're down to these four. Let's rule in and out stuff. But, I mean, this was one of my original guesses, so we'll keep that on the table for sure. AFib looks slightly too regular for that. And also, AFib doesn't really explain why there are subtle changes, but it does look fibby here. AV nodal reentrant tachycardia. Depending on where it's re-entering from and like how big that re-entry circuit is, that could cause some variances. Yep. It does look AVRNT-esque here. I'm going to say that. I'm going to say AV nodal reentrant tachycardia. That's my primary guess. This will be my secondary guess. I'm going to give this 60% certainty, maybe 70. And I don't know, it kind of looks like it has a couple things of both. Tough. Atrial tachycardia, honestly, I don't really see that enough to be able to intelligently talk about it, but I don't see any atrial activity. And if I do, it's post-QRS complex. Like, there. So that doesn't really fit with atrial tachycardia. That definitely fits with a flutter, because that could be. Oh no, usually the flutter wave is like more buried in it than that. Okay, well, it's that or it's that. It does look nodal reentrant tachycard-esque. However, the rate and the slight variability of the R to R is more consistent with a flutter with a 2-to-1 block. Honestly, 50-50. I don't know. I'm 50-50. I really am. But I will say the access looks a little bit too normal for AVNRT. Right around 150. I'm gonna say C. It's my first guess. It is probably going to be B. Yeah. So I don't know about classic. I wouldn't say that. There are some tough characteristics of the ECG. Tracing demonstrates a regular narrow complex tachycardia rate of about 150. The differential diagnosis are regular narrow tachycardia in general include 5 major mechanisms: sinus, AV NRT, atrial tachycardia, orthodromic atrioventricular reentrant tachycardia, involving retrograde conduction over a concealed bypass tract, which we talked about that, or a flutter with a 2-to-1 block. If P waves can be located, it can be helpful in determining the mechanism of the tachycardia. In this tracing, P waves can be located at the end of the QRS complex and lead to. All right. Maybe that's what they're calling it. I don't know. I see them best here in AVL. I don't really agree with that. Oh, rhythm strip. That. Yeah. In the beginning of the tracing, P waves are buried in the end of the QRS complex, but then gradually come farther out behind it. Okay, so we did notice the variability there. By the end of the tracing, inverted P waves can be clearly seen in the rhythm strips. Oh yeah, that's why it gets wider. It's slowly marching out. Okay, that explains it. That explains it. It's slowly marching out. Yeah, and that probably explains why this is a little wider over here. And then that goes away by the time we get over here. Cool. The finding rules out the diagnosis of AV reentry due to a concealed bypass tract, because there the R to P interval is fixed and it does not activate sequentially. Well, sorry, it does. So I don't really understand how. What is that actually saying? The R to P is fixed and cannot be as short as it is in the beginning of this tracing, since the ventricles and atria are activated sequentially. Oh yeah, there's no reentrant. Okay. Sorry, there is a reentrant. All right, well, there's a clear one-to-one AV relationship here with no extra atrial waves, ruling out a flutter. I mean, yeah. Now that I've read the answer, it does look like there's a little bit too much space here to conceal it. That leaves two diagnoses, AV NRT and atrial tachycardia. Often it is impossible to tell the difference between the two unless initiation or termination of the arrhythmia is recorded. However, in this case, there are subtle but important diagnostic clues, allowing one to infer the exact diagnostic. Note that not only the RP relationship is changing, but the ventricular rate is becoming faster. But that makes it seem irregular. At the same time, the P to R interval gets shorter. Usually, if ectopic P waves are conducted over the AV node, the PR interval increases with increased heart rate, consistent with the decremental properties of the AV node. Yeah, that makes sense because of the sinus, because of the nodal pause. In this case, PR interval gets shorter, suggesting that the P waves are unrelated to the subsequent QRS. Yeah, that makes sense. This strongly supports the diagnosis of AV NRT. The gradual increase in the R to P interval or slowing of conduction over the fast AV node pathway can often be seen in typical AV NRT prior to spontaneous termination. That typically occurs in the fast pathway. Slowing the fast pathway conduction results in more delayed engagement of the slow pathway, giving it more time to recover, hence the apparent shortening of the PR interval. Oh, yeah. Absence of visible P waves, the presence of a pseudo S pattern in 2,3 AVF, or a pseudo R prime. Yeah, there's no S wave. Pattern, which there is not, in V1 is characteristic of AV NRT due to the near simultaneous activation of the atrium and the ventricles from the AV node. If the diagnosis is still in doubt, adenosine, if not contraindicated by something like, can you give it Wolff-Parkinson right? I don't know. I'd be skeptical. May be useful in slowing conduction in the AV node. Reentrant rhythms, AV NRT or AV RT, may break abruptly, converting to sinus. The ventricular response of either atrial tachycardia or atrial flutter will sometimes slow abruptly, often revealing the underlying atrial activity. Note, the final wide complex waveform appears to be an artifact superimposed on an AV NRT beat. Yeah, we weren't sure, but it does look artifacty. Not because of the shape of it, but because the isoelectric line changed abruptly with it. Cool. That was kind of tough. 4. All right. Wow. Normal or abnormal? Very abnormal. Fast or slow? Fast. Access. Looks like it's primarily down here, primarily up here. That's right axis deviation. The rate is irregular, and I don't see any atrial activity. The QRS complexes are very wide. And the QRS amplitude, or the voltage, is very low everywhere except for here. So it's a very abnormal EKG, concerningly so. There's a right bona branch block with poor gain. I wouldn't be surprised if the auto interpretation feature of a monitor occasionally called this VFib. I would try to change the gain if I could, like double it to 50. ABR can't tell, it looks kind of biphasic. All these beats look relatively the same. I don't know, looks kind of AFibby with RVR and a bona branch block and poor gain. There's delayed ROA progression. Can't see any P waves. It's hard to say if there's T-wave abnormalities because the complexes are so small, but I would suspect that there are. It's also tough to appreciate the ST segment, but it doesn't look like there's any disproportionate elevation or depression. But there could be without a closer analysis. I think we've hit the end of this one. I don't know what else to say. It looks like AFib with RVR, a bona branch block, and poor gain. Why is the gain so small? The patient is really large. There's something interrupting the electrical signal between, if you imagine that this is the heart and this is the skin and all this in here is muscle, either there's more fat, there's more muscle, there is fluid, air, or blood in here, or the leads, instead of being placed like that, were placed wrong. And there could be chest hair. Bloop, bloop. Yeah, things like that. I think we have to get into this one pretty early because I have no idea. Severe mitral regurgitation history of adenocarcinoma presented to the emergency department in shock and died after aggressive resuscitation attempts. Oh boy. He did not have a pericardial effusion. All the following statements about this ECG are correct except for which one of the following? The rhythm is AFib. That looks to be true. Right axis deviation is present. We did say that. That looks to be true. The ECG is absolutely diagnostic of an underlying anterior wall MI. I mean, there is some ST elevation here, but it doesn't look excessive. And it is discordant from the QRS complex direction. I wouldn't say that, especially now that we know that they're post-ROSC. The ECG is consistent with non-ischemic cardiomyopathy. Oh boy, low limb lead voltage is present. Okay, so it's one of these two. But I don't know how to tell non-ischemic cardiomyopathy on an ECG. The only way that I can think is to rule in or out the presence of a strain pattern, and I don't see the presence of a strain pattern. So if there's cardiomyopathy here, there's no strain pattern, which means that the pathways and the tissue of the actual heart are still functioning without cardiac remodeling or a redirection of the vector of the normal axis or vector of the heart. So I'm going to say C, because I don't see what they would be calling, unless they're calling this a hyperacute T wave. But it doesn't look that egregious to me. I'm going to say C. The surprising diagnosis was cardiomyopathy associated with a widely disseminated adenocarcinoma of unknown primary origin. The ECG shows atrial fibrillation with markedly decreased voltage in the limb leads. They could have a tumor. Right axis deviation. A loss of R wave progression in V1 through V3. Yep, it's totally down. It should switch here. A transthoracic echo showed no significant pericardial effusion. Well, then what explains the poor voltage criteria? The differential diagnosis includes an anterior myocardial infarction. I suppose the anterior myocardial infarction would be the more likely one because the left main coronary artery and the LAD originate from that area to cause sudden cardiac death. So they would, if they were going to go get cath, they'd probably go for an urgent left heart cath. Myocarditis, yeah, any carditis can cause decreased amplitude. Severe chronic obstructive pulmonary disease, yeah, that could do it too. And an infiltrative process such as amyloidosis or more rarely tumor resulting in a pseudo-infarction pattern of this type. I don't know, that's kind of what it seemed like to me on first glance. However, as illustrated here, loss of R wave progression, sometimes with frank Q waves, is not pathognomonic of anterior MI. I don't really see any frank Q waves because the gain is so poor, but maybe here. Oh, let's see where we're at. 41 minutes. Okay, let's keep going. That one wasn't that bad. They should give like a 5-star because the other one was harder. Or maybe it's just areas that I'm weak in. Who knows? 4 stars. All right. Okay. That's interesting. Well, abnormal or normal? It's abnormal. Fast or slow? Doesn't really look horribly fast. 90 something beats a minute. Access, honestly, looks kind of normal. There is some suggestion of LVH criteria, but ultimately the R wave transition and the other cardiac access looks pretty normal. There is a left bottom branch block, and there is atrial activity, and it seems pretty consistent and regular. So this is a sinus rhythm, albeit it's a little bit fast, probably in like the 90 range. There's some notching here. The PR interval looks okay. The QRS complex is wide. Honestly, this T wave in V1 through V4 looks abnormal, and I can't really explain it. And then there's T-wave flattening kind of everywhere else. Should this T-wave be higher if this LVH caused an increase in amplitude? Maybe. Boy, I don't know what else to say about this one. There's poor gain. I remember I said I was going to mention gain more because I didn't do it last time. Low voltage amplitude here. We've mentioned some of the reasons for it already. I don't really know what would cause a coved shape. I mean, like the ST segment's almost not even there. I don't even know how to identify the J point here. Maybe it's there. This is a very bizarre looking T wave. I would actually say bizarre appearing T wave in the anterior, anterior septal area. I can't tell if that's a U wave. It's very subtle if it is. Kind of looks like it might be though. There's a little dip here and here too. So maybe there are U waves. I don't know. I need more context. Electrolytes. The PR interval is fine. The QRS complex is a little bit wide. The QT interval actually looks fine. It may even be a little short. There are significant Q waves in lead 3, to a lesser extent AVF. I don't think that this is ST elevation. But the complex is so small that it could be, this could be a disproportionate size, like But in the presence of a right bundle branch, left bundle branch block, you would need to apply scarbosa. And because it's so small, I don't know. This could be an MI. But I don't know. This looks so weird. Okay. Oh boy. Previously healthy 49-year-old man, muscle weakness and constipation. No chest pain, no dyspnea. I wouldn't say hyperkalemia. Maybe though. Hypokalemia? No, it could be hyperkalemia. Patients with potassium abnormalities do present with bowel things. But the shape of this is too round to be hyperkalemia. That would be atypical of hyperkalemia if it was that. Normally it's like a little bit more tented than that. And then the T waves are just so small here, but there definitely doesn't have to be T waves that are large in this part of the heart to have this actually be hyperkalemia. The weakness supports, well, really any electrolyte abnormality can cause weakness. But it actually supports hypercalcemia the best. It may be hypokalemia. Hypokalemia supports constipation more. Hypothyroidism, I have no way to determine that just based off the EKG alone. This is going to be probably the biggest guess that I take out of all of these I've done so far. Let me just say what I think. Hypothyroidism, I don't have enough information or knowledge to be able to say why that is. The rate looks a little bit fast, so I'm going to say it's not that. Hypercalcemia. There's a normal PR interval. There is a shortened QT. Usually with calcium issues, you do see QT changes more than with potassium issues. So I'm on the calcium fence now. Hypercalcemia specifically will cause weakness compared to hypocalcemia. I'm going to say D. Honestly, I give myself a 30% chance that that's correct. A very short ST segment. Yeah, it's like blended in. That's why this looks so weird. There's like no J point with a consequently short QT interval. Very short. We saw that. The differential diagnosis of a short QT, well, it could be digoxin because of the quote unquote dip that skews the QRS complex and shortens the QT interval. Differential diagnosis of a short QT, lower limits are not well defined, is much narrower than a prolonged. The two chief causes are hypercalcemia and digoxin therapy associated with the characteristic scooping of the STT complex. A third and relatively rare cause is hereditary short QT or channelopathy that may be associated with ventricular arrhythmia and sudden cardiac death. It's like torsades. They're referencing something from 2000, cheapers. Cardiac arrhythmia is, however, unusual with hypercalcemia, but AV block, sinus arrest, and atria block, ventricular tachycardia, and cardiac arrest have been reported. Usually in patients receiving rapid IV injections of calcium. Oh yeah, I can see that. Yep. The patient's serum calcium was 16. That's really high. Oh, hyperparathyroidism. Yeah. Yep, those are usually caused by cancers or some sort of not cancer, but some sort of cancerous like adenoma or whatever. Would it be called an adenoma? Anyways, he had successful resection of a parathyroid carcinoma, an unusual cause of hypercalcemia. It does happen though. Sometimes it can last years. These people don't get treated early enough, so they have like bowel issues and joint problems and like skin issues and like a whole bunch of other vague symptoms. Cool. That was a fun one. Yep. Beep, beep. Time for one more? I think so. 2, 4. Oh boy. On my 5-second analysis. Cerebral. Having Wellens in multiple areas of the heart is uncommon. Could this be a reperfusion? Maybe. That is very deep. This is probably an unresponsive person. This looks cerebral, but it's normal there. I have seen Wellens down here before, but it's not really located in. So that's the weird part, is it's not really located in congruent areas of the heart. Sure, these are all next to each other, but why is it in AVL in 1, 2, but not 3 in AVF? So there's gross T wave, deep T wave inversion. There are P waves, and the PR interval is normal. The QRS complex is narrow. The rate is not horrible. What is it? 60 to 75, 70? It's not bad. It's a pretty normal rate. It's all sinus. All the PR intervals look relatively the same, and the rate appears regular. There is marked left axis deviation. This is either a reperfusion injury of like multiple vessels, or there's a cerebral thing. If the patient's unresponsive, it's a stroke. If the patient's responsive and complaining of like chest pain that resolved, then it's going to be some sort of a reperfusion injury. There is some ST elevation in AVR with an upright T wave. And that's abnormal. That's interesting. Could this be a toxin? I suppose it could be. Let's see. Bicuspid aortic valve. Interesting. Aortic insufficiency, hypertension, episode of chest pain 2 days prior to this tracing. Oh, yeah. Without clinical information, this type of pattern of T-wave inversion is least likely attributable to which one of the following? A non-Q-wave MI and with Wellens syndrome. I mean, that's kind of what it looks like. Evolving pericarditis, I've never seen. Pericarditis cause such significant and global T-wave inversions before. Central nervous system pathology, yeah, we talked about that. Apical hypertrophic cardiomyopathy, it could certainly be that. Takotsubo syndrome, broken heart syndrome. That usually shows up as like a STEMI equivalent, or like STEMI-esque. So the answer is either B or C. Given that this patient has a lot of cardiac history, I'm gonna not rule out a left ventricular aneurysm, because a left ventricular aneurysm can certainly cause some sort of like remodeling type of like temporary acute. I'm gonna say C. Pericarditis, I've never seen that. The ECG shows a sinus rhythm about 65 with diffuse prominent anterior T-wave inversions consistent with probable ischemic non-Q-wave myocardial infarction, otherwise known as Wellens. Sometimes this pattern is referred to as Wellens T-waves. Angiographic and clinical characteristics of patients with unstable angina shows an ECG pattern indicating critical narrowing of the proximal LAD. Could be the left main as well. The ECG also shows findings consistent with left atrial abnormality. I didn't actually notice that. Where are they looking? I guess it's slightly biphasic there. In there. I didn't even notice that. Along and left ventricular hypertrophy. Yeah, we do see that. I didn't say that, but that's definitely true. These RS complexes are very large. Along with non-specific mild PR prolongation. Huh, it looked okay to me. Oh yeah, I guess it's borderline. QT prolongation for the rate. and borderline left axis deviation. Borderline? Sure. That looks a little bit more than borderline to me. Ischemia infarction should be on the top of your differential diagnosis in the patient with the recent chest pain. Yep, we said that. We said if they're unresponsive, it's cerebral. And we said if they had chest pain, it's Wellens. A tracing during the episode of chest pain revealed, 1 to 2 millimeters of ST elevation and 1 AVL up, they need a cabbage. Cardiac catheterization revealed non-critical coronary artery disease and global left ventricular dysfunction. A subsequent echocardiogram taken on the day of this tracing revealed normal. Oh, wow. Most likely the patient had a transient thrombus or spasm of the proximal LAD with severe myocardial stunning. That's what's caused. Severe myocardial stunning is what's caused this. It looks like a reperfusion wave. Enzymes were only slightly elevated. Man, this is the most egregious Wellens I've ever seen. This is very atypical for Wellens to be in such prominent areas. Other specific diagnosis to consider in a patient with diffuse deeply inverted T waves is CNS disease, not clinically present here. Tumor, intracranial hemorrhage, head injury. Apical hypertrophic cardiomyopathy. Oh yeah, for sure. Usually most marked, but that would have some QRS widening, I would think. Mid-lateral precordial leads, intermittent right ventricular pacing, or intermittent left bundle branch block. Yeah, yep. If it was present enough to cause cardiac remodeling, go back to this, right? Like as the heart remodels, it begins to like restructure and then things work differently, right? That's called cardiac remodeling. But then if that heart rate, like let's say it's rate induced and it's only like that when their heart is beating fast and now they're at rest, and when they're at rest, it goes like normal. So you could have a non-wide QRS complex, but they could have had this intermittent bundle branch block for so long that cardiac remodeling actually took place. I forgot about that. That makes sense. However, memory T waves, yeah. But this syndrome is usually associated with upright T waves in one AVL. Yes, it is. Yep. It's usually this area where you see the strain. Pacing. You can definitely see it there. Takotsubo stress cardiomyopathy, left ventricular apical ballooning pattern on angiogram, and idiopathic global T-wave inversion, a disease of a diagnosis of exclusion. Honestly, I don't really know what that is. I've never even heard of it. Pericarditis may be associated with diffuse T-wave inversions, but they are relatively low amplitude. Yeah, that is true. Yeah, some slight STT changes, but definitely nothing this deep. Cool. That was a fun one. All right. That's the end of this series. We're under an hour. Thanks for tuning in.